Again, thank you for the invitation to the lovely city of Rome. And my talk is how to manage CML at MD Anderson in 2022. Curative story, success story, outcome of CML patient today is normal, close to the normal population. Survival at 10 years surpasses 90%. So the bad news to deliver to a patient, you have cancer. The good news is you will live normal lifespan. And this is a study published by my colleague, Dr. Sasaki from MD Anderson, where we look into our database and we compare survival to normal population. So we match patients the same age, same characteristics. As long as you respond and you achieve a CCYR at least, the 5-year relative survival is 95%. So therefore, it's what I said at the beginning, patients with CML, if treated appropriately, can expect to have a normal lifespan. 2022, we have several drugs available. The last one to be added to the armamentarium is asciminib, approved today for relapsed refractory disease. And we have a new compound. One of them is HQP1351, very promising. You'll see data at ASH this coming year in New Orleans. Still, several questions are to be asked. What is the best frontline therapy? Generic, imatinib today, but we have dasatinib coming soon. What is the end point of therapy? Curing somebody or letting them live a normal life? And if that is the case, at what price? Role of transplant, and how we manage salvage disease, relapse disease, how we sequence this TKI available. So at MD Anderson, what are the factors that drive us to decide on a TKI? There are 5 factors listed in this table. Age and aim of therapy. Younger patient, you may opt to go for treatment-free remission, and therefore, in that sense, you may want to opt to use second-generation tyrosine kinase inhibitors. For older patients, let's say somebody who's 90 years old, TFR may not be a priority for this patient, but to complete the lifespan. Therefore, older patients, survival is the goal, and imatinib is a good fit. 2 factors, therefore, age, aim of therapy, cost. Can you afford the drug prices? Second-gen TKI are expensive today. How we choose among them? Generics are available in the USA. There's something called Cost Plus, $500 per year for imatinib, which is quite reasonable. CML high risk of transformation, and therefore high risk so-called scored disease or UTOS or Hasford, you name it, second-gen TKI. And finally, comorbidities. Remember, CML patient median age being 65, therefore obesity, hypertension, diabetes, all these are risk factors, and when we select TKI, we should take into account these factors. So what is our sequence of therapy in Houston today? Our frontline therapy is dasatinib 50 milligram per day, and I will show you the data. And if that doesn't work, then ponatinib is our second line of therapy. The dose is 45 milligram per day, mainly in T359 mutation, and of course, if you have other mutation, you can go to 30 milligram, reduced to 15. If ponatinib cannot be an option, then bosutinib is an alternative. If we're starting with imatinib 400, then our second line therapy is dasatinib or bosutinib, and if that failed, then ponatinib. We do not use often nilotinib in the front line because our patient population are at risk of cardiovascular events, and we know from the NSND trial that the cumulative risk of vascular event is around 25% at 10 years, 2.5% per year. And finally, we never shift TKI because somebody is intolerant, because they have nightmares at night, or they have jet lag. No, kidding, we don't switch for jet lag. But that being said, we try to optimize supportive care before we declare somebody intolerant. So here's the IRIS trial, the landmark trial that established imatinib as standard of care. Despite a crossover within 6 months, there's 5% difference in survival. That means you need to implement your most effective therapy at diagnosis. There's no watch and wait strategy like we do in CLL. Frontline therapy, 16 randomized trials that have shown that second-gen TKI and even third-gen TKI are more effective than imatinib in inducing deeper and faster responses. None of them has shown a survival benefit. Maybe because we have a good salvage approach. So you can go on imatinib, failed, you can get second line, third line, and survival we preserved. However, keep in mind some serious adverse event that can be encountered with second-gen and third-gen TKIs. Which drug is better? Dasatinib or nilotinib? Equivalent. No difference. A randomized trial done in Japan showed equivalent efficacy between the 2 drugs, so you can use either one when it comes to efficacy. No, this is what I showed you on with the NSTND. We have no impact on survival, but risk of vascular events are increasing with time. Therefore, we must optimize these factors up front. And one thing in Houston we ignored for a while at the beginning, if you go to MD Anderson, or you arrive to the clinic, you're exhausted, intimidated, and you check blood pressure by nurse, and it's quite high. It's white coat effect. It's not true. It's TKI effect, and therefore we must adjust hypertension. In Houston, we embarked into 50 milligram trial of dasatinib in a frontline setting. We've treated 81 patients, and we have an update at the ASH meeting. But we did a study because dasatinib at a lower dose was found to be effective and with less toxicities. So we designed a phase 2 study, and we put early stopping rules if we don't meet efficacy endpoint. And surprisingly, the 50 milligram per day was found to be better tolerated and higher efficacy. If you look at the MMR rate, and I'm comparing here to dasatinib 100 milligram and imatinib, you see dasatinib induce higher rate of 12 months MMR. The question why that? The answer is because of a minimal interruption, and the rate of pleural effusion grade 3 and 4 is reduced significantly. And we did propensity score matching, we just published in HEH this summer. The results, when you compare to 50 to 100, 50 was found to be inducing faster, deeper responses and less toxicities, mainly less pleural effusion grade 3 and 4. It dropped from 21% to 5%. That's why we have a fatal-free survival in favor. Now, the caveat of the study is we enrolled younger patients, and only a minority had a high so-called score disease. Still, at MD Anderson, what we're using up front is dasatinib 50 milligram per day. How do I treat CML in chronic phase 2022? Again, generic imatinib 400 milligram per day. If patients have to pay a lot of money for insurance is a problem. Dasatinib 100 milligram is standard of care, although at Anderson we're using 50 milligram per day. Bosutinib is 400 milligram in a front line. At Anderson we use a lower dose and we escalate thereafter. Nilotinib is available as well, however it's avoided because of vascular problems. If your goal is survival, any of the above option is appropriate. For high so-called score disease, we do favor second-gen TKI. And if TFR is your goal of therapy, then we favor second-gen TKI. And remember, your TKI of choice must depend on age of the patient, aim of therapy, comorbidities, and what you're aiming to accomplish in adverse events. This is how we select our frontline therapy in Houston in 2022. Monitoring is the goal of therapy as well. It's not only enough to prescribe a drug, but make sure the patient is receiving his medicine, and PCR is established for monitoring of disease response. Every 3 months the first year till MMR is achieved consistently, and then we go to every 6 months thereafter. If PCR is increasing, check compliance, repeat the PCR before we make a change of therapy. For survival, PCR should be below 1%. Therefore, I do not switch my TKI if patient PCR is above 0.1%, as long as it is below 1%. I offer treatment discontinuation if I can use a deep molecular response for at least 2-3 years, if not 5 years. I will only check for mutations at the relapse, not at the baseline, because it does not matter for my treatment strategies. And finally, the interpretation of the result should be take into account what's available as salvage approach. End of therapy, survival, treatment-free remission, long-term safety, and the cost of the drugs. Just some definition, how we define deep molecular remission. Deep molecular response is everything below 0.01, MR 4.5. Durable, if 2 years is the duration, the success rate is 50% for TFR. If you go to 5 years and longer, you can improve your TFR rate to 80%. This is the EuroSKI trial, the biggest trial that established TFR and confirmed the initial findings. Essentially, around half of the patient can benefit from a TFR. Although we don't see a plateau, means patients are still relapsing at the long run, although a minority, that tell us we should monitor our patients very carefully. The question is how we improve on this success rate. Well, it depends on the criteria used to stop therapy. In a EuroSKI, for example, they established MR4 for 1 year and longer, and in a STEAM trial from France, MR 4.5 for 2 years and longer. So if you have strict criteria before you inducing treatment for remission, then your success rate is higher. It goes from 50% to 64%. In Houston, we reviewed 300 patients. We just published this year as well. And we've shown that if you're at least MR4 for 4.5 for 5 years, our success rate is 85%. So in my hospital today, I do 5 years of deep molecular remission before I offer treatment discontinuation. Now, once you stop therapy, it's very important to monitor your patients. Standard ELN criteria, guidelines and NCCN is to do PCR monthly for a year, then every 2 months for the next year, and every 3 months thereafter. I think it's too much. In Houston, we do every 2 months for the first year, then every 3 months for the second year, and beyond and then every 4 to 6 months from year 4 and onward. I do not restart TKI for only one result. I will repeat my PCR within a month or two, and if it's consistently loss of MMR, then I can go back to my TKI, very likely the TKI that patient was receiving before. Frontline therapy in 2022, how we can make it better. We did design a trial that we completed. We showed it at the ASH meeting, combining dasatinib and venetoclax with the idea to improve deep molecular remission and offer more treatment-free remission. So far, we have not met what you can accomplish, but the data will be shown. Right now in Houston, we're combining dasatinib plus oral HMA therapy. First 3 months of dasatinib, 50 milligram per day, and then from month 4 and onward, we add 3 days of HMA or the Aztecs compound. The study is ongoing and accruing today, and the goal is to improve the rate of deep molecular remission within a year and offer more treatment-free remission possibilities. In the relapse setting, all second-gen TKI equivalent. These are the summary of the pivotal trial done, 50% response rate. Although PFS may not be so durable at the long run, patients are still losing their response, and therefore there's a need for third-line therapy. We did an exercise to establish which one is the best TKI to be chosen in the second line. I think when it comes to survival, they are identical. When it comes to responses or PFS, nilotinib seems to be a little bit weaker than other TKIs because of the cross similarities when it comes to the mutation profile between imatinib and nilotinib. Ponatinib is a pan-BCR-ABL inhibitor. In a PACE trial, it has shown in patients who failed multiple TKIs, 50% can regain their CCYR, and the 5-year survival is around 80% for this patient, which is not bad. However, the drug is associated with the vascular events, mainly at 45 milligram per day. In a meta-analysis done in a third-line therapy, Dr. Lipton has shown that ponatinib is superior. Therefore, we should not rotate second-gen TKI if resistance is a problem. CCYR rate goes from 25% to 50% with ponatinib. Now, there's a new drug, asciminib, that was recently approved based on a randomized phase 3 trial called the ASSEMBLE. I will show the results. And there's other agents. I'm most excited about this QP1351. We're leading the trial in Houston today. So the question is, and you're going to hear more about it on Wednesday, ponatinib or asciminib. Asciminib is an allosteric inhibitor of the BCR-ABL. So let me go over the ponatinib first. Ponatinib was assessed in what they call the OPTIC trial, which is a phase 2 trial, randomized trial, 45-15, 30-15, and 15 all along in patients who failed multiple TKIs. The primary point was rate of BCR-ABL transcripts of 1% at 12 months. The 45 milligram arm was the winner, starting at 45, reduced to 15, and this benefit was mainly seen in patients with P359 mutation, where the CCYR was 60% with the 45 compared to 25 and 11% with the lower dose schedule. Of course, the efficacy benefit was highly seen with the 45 and 15. And then when we compare the PACE to the OPTIC, mainly at 45 milligram per day. So in a PACE, we reduce the dose based only on toxicities. In OPTIC, we reduce the dose based on safety of, based on the efficacy of the regimen. You can see here, when it comes to efficacy, the OPTIC has maintained, if not surpasses what was seen in a PACE trial. However, the median exposure of the drug is way longer, and then the safety profile is way safer. By adjusting for the time, it dropped from 16% to 7.6%, the rate of vascular events with 100 patients per year. The ASSEMBLE was a randomized trial on patients who failed 2 TKIs, getting asciminib at 40 milligram BID compared to bosutinib. 359 were excluded. Here, the characteristic of the trial, although it's a randomized trial, there were more favorable features in the asciminib arm compared to the bosutinib arm. The primary point was MMR at 24 weeks. The primary point was met and led to the approval of asciminib, 25% compared to 13%. We've seen with asciminib already vascular event encountered at 3.2% compared to bosutinib of 1.3%, with new mutations being encountered as well on therapy. The update from ASCO this year and EHA, the MMR rate still in favor of asciminib. Of course, it will be because patients who are on bosutinib are being withdrawn, taken off the study. However, that did not translate into improvement of PFS and survival. No difference between the two arms. Bosutinib had diarrhea, led to discontinuation of the drug. We see more discontinuation on bosutinib arm compared to asciminib. I like to highlight that the dose of asciminib is 40 milligram BID or 80 milligram daily, which is not the dose approved for T359 mutation, being 200 milligram BID. So in summary, we have frontline therapy, many options, or are excellent, and I think they're getting better but cheaper. Second line option equivalent, I think ponatinib is the drug to be given post second gen TKI failure. I do not rotate my second gen TKI. In a third line, ponatinib with a dose adjustment had a better efficacy safety profile. Asciminib is an alternative to be considered. Remember that all these TKIs are approved at a higher dose than they should be. Therefore, dose reduction are effective and safe without compromising efficacy. Treatment discontinuation is a reality. However, aim for have a deep molecular remission for as long as possible before stopping TKIs. We have very exciting TKIs still being explored, and we're working on strategies to improve TFR. And finally, keep in mind, these are all patients. We need to optimize their comorbidities to minimize safety concern. Thank you very much for your attention. Happy to take questions.